over to Rati ma'am. Thank you.
I invite Dr. Vishnu Mohan, our State Secretary, to say a few words.
Very respected Anandakeshavan sir, our Vice President CIAP South Zone, President Manoj sir, Dr. Rati Madam, President IAP Thrissur, Dr. Murli Raj, President of TNF, and seniors and all my dear friends. It's indeed a matter of great happiness to felicitate this meeting today. Especially because when we took over as the office bearers of NNF Kerala in 2019, Manoj sir, me and Dr. Nilbi, along with nurses empowerment, e-learning for doctors was one of our action programs where we put a lot of efforts in. And we had conducted 5 e-learning modules earlier, which well appreciated. And I congratulate and thank TNF along with IEP Thrissur for carrying forward with our action plan with the 6th module. And I wish all success for this program and wish all the delegates a wonderful week of learning. Thank you.
Thank you, Dr. Vishnu. I request Dr. Verma to moderate the scientific session and to introduce the speaker for the day. Please unmute Dr. Verma.
Thank you, Dr. Reddy. I'm quite pleased to chair this session, the first of the 6 ventilation sessions organized by the Thrissur Neonatology Forum. I'm much obliged to Dr. Murli for asking me to chair the first 3 sessions. The first of the sessions, and rightly so, is done by Dr. Manoj, who is the president of the NNF Kerala. And I'm sure that the ventilation is an important part of neonatal care. And the basics of neonatal ventilation should be known by all the PGs who are graduating from the medical college. And I am sure that Dr. Manoj needs no introduction to this audience. He has done a lot of work both in neonatal as not only for the medical fraternity in the academic side, but also on the other side as well, for the health of the medical fraternity. And I am sure that this will be an interesting session. And those who want to ask questions, please ask questions in the chat box. And I would request all the others not to clutter the chat box with anything other than the questions, because there is no question answer box here. So ask questions in the chat box, or you can ask directly. But directly it will be a bit difficult because there are already around 190 attendees. So asking questions will be, if you directly ask questions into the mic, it will be a mayhem most of the time. So please ask questions in the chat box. Don't clutter it. If you want to chat personally. So now with this introduction, I now request Dr. Manoj to take over and do his deliberation. Dr. Manoj, please.
Good evening, friends. Let me, on behalf of NNF Kerala, also welcome you to the series, part of the learning series that we have. Now, in the next 6 webinars, we are trying to look at one of the topics which is said to be the bread and butter of neonatology, especially right from the beginning, the modern neonatology began, but which has undergone a lot of evolution. And so it is probably a very challenging task to devise this. So we have actually devised this into 6 modules. The first one being today, and on the very basic concepts, and then subsequently we would be discussing the various other aspects like the how to initiate, and then subsequently how to monitor with the blood gas, and then how to wean, and then little bit of pulmonary graphics, and then disease specific ventilation. So please feel free to interact. You can, if at all you feel that your questions are left out during these you can as well write your mail your questions to kerala@gmail.com. It will be answered also in case you are, because sometimes it becomes difficult to answer all questions. And please feel free to voice your comments as well. This is a learning ventilation, I would call as a learning process for most of us. Because why? Because we all learn every day, and today this is the day of precision medicine, when everything is individualized, and ventilation also has undergone lot of changes that way. So we now talk about gentle ventilation, we now talk about ventilation also. So there are a lot of new things coming up in the ventilation. Discussing any of those, we will be basically discussing only the basic things, but then of course we are open to discussion. So with that, we will start. Today we will try to look at the very basic concepts in lung physiology and what happens when a lung becomes pathologic, and how do you really ventilate this lung, and how does a ventilator work, and what is the basic function that the ventilator does, or how does it oxygenate, how does it eliminate CO2, and then we'll just incite some thinking and just have a very brief look at the evidence for volume targeting in units. So what is ventilation? Ventilation, we all know, is movement of gas in and out of anything. Your building, you have a ventilator. In lungs also has a ventilator, and that is your airway that helps the lung to move air in and out. So this concept has to be understood in the context of the baby, because we treat babies, not the lungs. So when you treat a baby, the ventilation pertains to probably one parameter, that is the partial pressure of the carbon dioxide in the baby's blood. That is what is going to tell us the adequacy of ventilation. And sometimes, because ventilation involves movement of oxygen in and carbon dioxide out, but oxygen in is riddled with other parameters, like how much oxygen that is given has been taken up by the heart. So the cardiac function, the blood pressure, the blood vessels, the oxygen carrying capacity of the blood, and the diseases, the comorbidities like sepsis that cause third spacing, capillary leak, all these are going to affect your oxygenation. But ventilation per se, we won't be touching on any of these. We will be touching on how to ventilate a baby. So your gold standard is going to be PCO2. All of us have in our physiology days seen this graph, and we start with this graph. We know there are volumes and capacities. And the volumes, when you add two or more volumes, you get a capacity. I am particularly interested today in one of the capacities, that is the functional residual capacity, the volume of gas left in the lung after a quiet expiration. And probably this is the sum of the residual volume in the lung and the expiratory reserve volume. I am also interested in one more parameter, the tidal volume, the volume of gas inspired or expired during quiet breathing. This is all what you need to really look at every time when you ventilate a lung. And of course, tidal volume alone per se does not guarantee everything, because babies don't come with a guaranteed brain, which means that the respiratory rate plays a part. So that the product of respiratory rate and tidal volume is what is actually important for you. That is the minute ventilation. Now, why is FRC important? FRC is what actually tells you the continuing descending pressure that you have, or rather what is the baseline for you, the baby to breathe. That is what you call as a positive end expiratory pressure, or CPAP. So until you ensure that there is adequate functional residual capacity, babies will find it difficult to breathe and they will have respiratory distress. So the first thing that you would need to look at is your FRC, and make sure that your PEEP or CPAP is adequate. But then CPAP alone is not enough for you. You need to ventilate. So here is where the tidal volume comes, and I'm going to tell you one specific value, because this is a basic class, 4 to 6 ml per kg. So this is a golden figure, probably not what you learned in your textbook or what you would do in adults. Probably you know the tidal volume is 4 to 8 or 4 to 10 ml per kg. But we said at the beginning that we are really talking about gentle ventilation, which means the minimum that you want to do, you do to make sure that the baby take over. So the minimum is 4 ml per kg. So 4 to 6 ml per kg in conventional ventilation is what you would be targeting. Probably there are other advanced modes we will not be covering in our this series, like high frequency, where the tidal volumes are different. So we said that the practical gold standard parameter for you is minute ventilation, which is a product of tidal volume and respiratory rate. So suppose you want to give 4 ml per kg and the baby is breathing at 60 breaths per minute, you are looking at something like a 240 ml. So now what I would request all of you to remember is this golden figure, 200 to 300 ml per kg. If you are able to maintain a minute ventilation of 200 to 300 ml per kg, look beyond lungs. Your ventilation is perfect. There is nothing wrong with the ventilation. Your problem is beyond lungs, maybe in the heart, maybe in the blood vessels, maybe in the tissue, anything else but this thing. So this is a golden figure, even though we know that physiologically, in physiology textbooks, we read higher values, 200 to 800 or 200 to 600 ml. We don't want those values. It is a crime to ventilate a neonate with anything more than 300 ml per kg. And now, what is minute ventilation? Minute ventilation is a gas that goes in and out of lungs in every minute. And this is actually going to ventilate two specific areas. One is the alveoli. That is what you want. That is your alveolar ventilation. But it is going to pass through the dead space also. It's going to ventilate your dead space also. So minute ventilation is a product of alveolar ventilation and dead space ventilation. And here is a catch. Actually, your gold standard is alveolar ventilation. You are not interested in ventilating the dead space. But then that comes as a package. Unless you do under a research setting, you cannot measure the alveolar ventilation. So the best parameter or the gold standard that you measure when you ventilate a baby should be minute ventilation. And what is the figure? 200 to 300 ml per kg. And there comes the catch. It is not this 200 to 300 ml sometimes has some problem. So you need to really make sure that the dead space is properly catered for. I'll tell you an example. A 3 kg baby, so you want to ventilate with 4 ml per kg, so you give 12 ml tidal volume, each breath you give 12 ml per kg. And in this 3 kg baby, that I'm talking about a term baby, half is dead space, half is alveoli. This is just rough for, I have simplified the concept. So which means 6 ml is going to dead space, 6 ml is going to the alveoli, and so your minute ventilation will be 6 ml into respiratory rate. That will be alveolar ventilation. Now imagine another scenario, a preterm baby, 1 kg baby. If you are going to give 4 ml only, 4 into 1 is 4, so your minute tidal volume, the 4 ml what you give is going to be unevenly distributed. The 75% of this is going to be in the dead space. Only 25%, 1 ml only will go to alveoli, which means that one golden figure does not stand good for all the babies. You need different values. So 4 ml per kg is good for a term baby. It may not be so for a preterm baby. Dead space is proportionally much more significant in smaller babies. So if you extend that, smaller babies need proportionately larger tidal volumes while ventilating. So your tidal volume target in a preterm should be somewhere around 6. I would ventilate with 6 or 7 ml if I am ventilating a 24 or 23 weeks baby, and then as I reach 40 weeks, I would use 4 ml per kg. So this is a rough idea of how this figure can sometimes mislead you, but you need to start from somewhere. So a preterm baby, probably you start with 6 ml per kg, and a term baby you start with 4 ml per kg. Then you can titrate upwards and downwards, because all babies, as I keep saying to my fellows, all babies do not read textbooks and come out. So they don't know that they require only 4 or they require 6. So, but you know that you can taper up or down. So start with these values, and tidal volume also requirement goes up with the number of days that the baby undergoes. So these figures, whatever I am talking today, are valid only in the neonatal period. As the baby grows, alveoli, the changes that take place, the proportionate growth, everything will result in an older baby. Second, in week 2 of life, its requirement of tidal volume will be less, is more than week 1 of life, and this keeps going on. And in disease conditions, like which we probably will be just mentioning at the end, like Meconium-Manod, you would require Meconium aspiration syndrome, you would require a larger tidal volume. So smaller babies require larger tidal volume. So 6 ml per kg for a preterm baby. Now this is, I just try to simplify the physiology, what you should remember. We all know we studied physiology for 1.5 years, so it's a large topic. But then let us try to look at what is going wrong when you need to ventilate a baby. When you need to ventilate a baby, obviously there is a problem. So are we ventilating a pathologic lung or a normal lung? Sometimes we ventilate a normal lung. Why? Because we know that lungs is okay, but baby is not breathing. There may be a problem with the brain, or there may be a problem with the heart. So we need to really remember this concept. We should know the pathophysiology of a ventilated lung for this. And it is actually best, I try to explain this in the very simple way of saying, why does a baby need to be on ventilator? It is to meet the work of breathing. And to meet the work of breathing, it needs to spend energy. So this is what you're going to provide. And this energy is required for, just remember, 3 basic things that don't work in a pathologic lung. The baby need to every time expand the lung against the elastic forces. It doesn't happen sometimes, especially when you have a baby with respiratory distress syndrome. We all know preterm babies, they find it very difficult to do this. Sometimes we need to overcome the viscosity of the lung and chest wall. Sometimes we need to overcome the airway resistance during movement of air into the lung. So work of breathing, if you really want to take into consideration, you need to look at 2 parameters, the compliance of the lung and the resistance. Resistance consists of the tissue resistance as well as the airway resistance. And until you cater for the work of breathing, you would not know what is the ventilator setting that you are going to use. So we'll discuss little bit. I know this is a boring topic. I'll try to make it very simple. What is compliance? Well, definitions we have all studied during our PG days. It's the property of distensibility of the lung and chest wall. So lung compliance is different, chest wall compliance is different. You want a rigid chest wall and you want a compliant lung for ideal respiration. So the compliance, if you want to define it, it is the change of change in volume that take place whenever you change the pressure. So the formula would be delta V by delta P. The normal compliance of a neonatal lung would be 3 to 6 ml per centimeters of water, and we all know the typical example of low compliance is your Hale membrane disease or RDS, where the compliance is as low as 0.5 to 1 ml per centimeter of water. All of us have blown balloons in our childhood, and this is the best way to understand the concept of compliance. When you start blowing the balloon, initially you find you need to use lot of flow, means you need the work of breathing, or rather the work required to fill the balloon is quite high. Once the balloon fills up a little bit, which in our practical terminology today means baby has attained functional residual capacity or your CPAP. Once you have provided the CPAP or positive end expiratory pressure, it's very easy. The compliance drastically drops, as is illustrated here. And after some time, if you keep on blowing the balloon, after some time you find it's very difficult to blow further. This is a gray zone. Mind you, you stop there. You don't stop it, you blow the lung out. So probably when the compliance, so you need to look at the lung compliance at with the pressures that you're using. When the compliance is falling as you go up, that means you are crossed the safe zone. So this is how we understand this concept. So I would introduce you to the first graph, which again next week we will be talking more about pulmonary graphics. That is this is probably what we are trying to depict is the change in volume per change in pressure. So initially when you blow the balloon, you don't find that much of volume change is happening. After a point, so this is your critical lung opening pressure. After that, suddenly slight change in pressure makes a drastic improvement in the volume. Until a point, after that, there is a beaking, which means that after that, further increase in pressure, this is again a dangerous zone where you don't want to ventilate. So you want to keep your optimal FRC at the critical lung opening pressure. That is how you decide. So this should be ideally, if you have this graph of the lung, this is where you keep your end expiratory pressure, PEEP. I will come to this concept again. So once you have done that, now it is very easy. So you ventilate here, don't go here. So maximum you are permitted to ventilate till this pressure, where your balloon is very easy to inflate. So this is the maximum pressure that you can go. That should be your peak inspiratory pressure or PIP. And here you get, with small change in pressure, you get maximum change in volume. That's what you want in life. You want maximum result with minimum effort. Now, just to give an intro about the disease pathology, suppose this is the compliance graph of a normal lung. A hyaline membrane disease or RDS lung will have low compliance, which means a more pressure, less volume will change. So it is a sleeping line. And a BPD or a chronic lung disease, the new terminology, chronic lung disease of prematurity, you find that compliance is very, very high. The moment you blow pressure, it will just blow out. So you find it is a standing line. So this is how you represent these three. Now, next week, I said we will be talking about various pulmonary graphics. So one of them is a loop called compliance loop, where you plot the inspiratory compliance and expiratory compliance. Anyway, wait for next week for that. Let's go to the next concept, that is the resistance. Now, resistance is very easy to understand. When you enforce something, somebody resists. That is the resistance. So when you push in air or when you flow gas, there is a pressure that develops. So it is a change in pressure per unit change in flow. That is your resistance. It is the inherent capacity of the air conducting system and the tissues to resist airflow. So you have two types of resistance, the airway resistance and the tissue resistance. Now, some practical tips when you ventilate babies. What is actually going to affect your resistance? One is the total cross-sectional area of the airways. So the proximal airways, probably will have less total cross-section area. So the resistance will be more, and as you go to the distal area, the resistance comes down. The length of the airway also will increase the resistance. So we need to use a small airway. So if you are going to put in an endotracheal tube, you are going to increase the resistance from the as compared to a normal airway. So make sure you put in the largest that is possible without damaging the airway, and largest and shortest. The flow rate also matters, and density and viscosity of the gas that you push in also will affect the resistance. Now, if you want to look at the unit of resistance, this will be important when I tell you the next concept. The unit, we said it is the pressure per flow. Pressure is centimeters of water and flow is liter per second. So centimeters of water per liter per second is your unit of resistance. And when this resistance is more, you usually encounter high resistance. If you encounter high resistance, you need higher pressures to ventilate that lung, and you need to push in this air for longer period. So your expiratory time is also going to be higher. Now, this is what I was mentioning previously, the location of airway resistance. Airway resistance is maximum, this portion. Thereafter, because of the surface area of the total surface area is more, the airway resistance comes down. Obviously, in the initial part, you don't have much cross-sectional area. So again, it will be, you have more, so it will be again coming down. Please remember, small ETT and high flow rate can increase the resistance. So if you use higher flow rate, your resistance goes up. So it's a good idea to use low flow, but how low can you go is the problem. Now let me introduce the third concept, that is time constant. A time constant is actually a product of compliance and resistance. So why do we need to know this? Because we need to set some parameters in our ventilator, and to set these parameters we should have some idea of, like, the parameter. One of the parameters that you set is how long you want to push in air, so the time the gas should flow. This is determined by the time constant. Each lung, whatever is the disease process, it will have a constant time based on the physiology of the lung or pathophysiology. So if you multiply the compliance and resistance, you get time constant, and one time constant corresponds to the time required to exhale 63% of the tidal volume. This is a figure you need to know. The calculations I can tell you, but then it will take a lot of time, so we will just skip that. Just remember these values. So if you want to push in all the air, 5 times the time constant should be the time that you would need to push in air. So pushing in air is the time that you use for as inspiratory time. In conventional ventilation, expiratory time is expiration is passive, which means that you don't have control over it. So you control only inspiratory time or respiratory rate, and indirectly control the expiratory rate. So unlike in high frequency ventilation. So here you push in air or the inspiratory time should be ideally 5. But if you use 5 time constants as the time required, then there are some problems. I'll tell you what is the problem. Let's look at a healthy term neonate who has a compliance of 4 ml per centimeters of water and a resistance of 30 centimeters of water per liter per second. So the time constant in a healthy term neonate is 0.12 second. So 5 times this means 0.60 seconds you have to use to push in air. And what is it that you are getting? You are getting 99% of flow. Whereas you can get a better value, 95, rather not a better, equivalent value, 95% of equilibrium with 0.36 seconds. So much of time you can save for preventing air trapping and allowing the baby to expire and give enough time, so that there is some leverage to increase the respiratory rate as well. So in practice, we use 3 time constants as the time set for inspiratory time. This value will differ depending on the pathophysiology. 0.36 is probably ideal for a term neonate, but this value will be different in different disease pathology. But then you know somewhere where you stand. Now, how does it differ? If you have a stiff lung, like in RDS, so your compliance is actually very low. So compliance and resistance is also low in RDS. So what happens is that the total time, the product of both is also going to be low. So the time constant required to ventilate this lung is only very less. So you can use a shorter respiratory shorter inspiratory time and faster respiratory rate for RDS. Opposite is true for CLD or CLD of prematurity or BPD, where resistance is high, compliance is also high. So here the product of both, time constant, the time required for at least 95% of gas to flow is higher. So you need to use higher time constant, which means the rate that you set should be lower. I hope I am making myself clear. We can discuss in the discussion session if this concept is not clear. So now we are going to the next part, which all of you know. I hope you know how does a ventilator work, because we are all thorough with the pediatric ventilation. So the basic physics of ventilator is almost same. The pediatrics, we use both neonatal modes and adult modes. So probably this is known to all of us. Still we will revise. Before that, can I request you to just give answer in your polling button? How many of you are using ventilator? So you're using routinely, yes, or yes occasionally, very rarely, never so far. So that I would know that how far I should be, what is the crowd that I am speaking to. Okay. So it's a mixed crowd. So So probably fine. That is fine. Yeah. So now, let's look at what is a ventilator. Ventilator can be called as a glorified T-piece. You have a T-shape. We all in delivery room we all use T-piece, isn't it? These days to ventilate a preterm, we use T-piece. To give delivery room CPAP, we use T-piece. So ventilator is also just a glorified T-piece. It has a source of air that goes into both arms of the T. One arm is your lung or the patient, and the other arm goes out, but there is a valve. And when the valve is closed, all the air goes into the lung. So that is your inspiration. Now, when the valve is open, what is happening? All the gas that goes will go out. Whatever was the pressure that was achieved here, all these gas will go till this pressure is equilibrating with this pressure. I will explain this concept further. So when as the valve opens and closes, you achieve ventilation. Now, another basic difference, let me stop and mention here itself. What is the basic difference between an adult ventilator and a neonatal ventilator? Adult ventilation, we always control the flow of gas with the volume. So it is a volume control ventilation, whereas in neonates, it is impractical to do volume control ventilation. There are some new research for those of us who are interested on negative pressure ventilation, where this concept is being tried. For those of us who remember the initial history of ventilation, ventilation started with negative pressure ventilation, just like the physiology ventilation, where we were actually using iron lung, the iron lung in the polio epidemic in US, the famous figure all of you must have seen. So now, adults, it's volume control ventilation. Neonates, it's always by default is pressure control ventilation, which means that the flow of gas is determined by some pressures that you limit. Now, let me explain this concept a little more. So you have a continuous flow of gas which will generate, so you need to generate some pressure, because we said ours is pressure control ventilation, PCV. Once you generate this pressure, then you let it, then the pressure is let go, and pressure will go go from high pressure to low pressure. So there is a valve here. When this valve is closed, the pressure here is very high, so this pressure, the gas has to go to the lung. The moment the valve opens, it will flow here, and the air in the lungs also will come out until it equilibrates with the pressure that is generated here. That is what you are going to set as a PWP, positive and expiratory pressure. So until that point, the lung will keep exhaling, and all this will go out. Now, who determines when to open and when to close? That is your cycling mechanism. So by default, all ventilators have a time cycling mechanism. And this flow is, this pressure generated with this flow is what you try to use up. Now, let me just jump topic and go on to something that I am going to discuss next week, that is the pulmonary graphics. So, the pulmonary graphics, you have waveforms and loops. So, I am going to tell you a little bit, give an intro about the two of the waveforms. One is the one that generates this flow of gas. The flow is essential. So when the piston valve closes, the flow starts, and the flow into the lung. Till then, there is no, this is a lung. We are talking about the lung. So imagine this is 0. So when the piston valve here, this is closed, means the flow can happen only to the lung, towards the lung. So that means there is a positive deflection and there is a positive wave, and this will keep happening till you reach a limit when the valve opens. And the moment the valve opens, pressure falls, and it will fall below up to a point that you set. That is here. I'll tell you. So, and then, so this is here expiratory flow of gas, and this is a inspiratory flow of gas. So this waveform is called flow waveform. how do you identify in a neonate? Flow waveform is always identified by the biphasic nature, the positive and negative deflection. Other two waveforms by default doesn't have. Probably when we discuss advanced concept, we will know that how pressure waveform has a synchronization, negativity and all that. So in general, you have a piston that closes and piston opens, and till then you have a positive flow, then you have a negative flow. Now this flow is going to generate into very, very important graph as far as a ventilator is concerned. If you call a biomedical technician into your unit and ask him to look at your ventilator, the first graph that he is going to look at is this, the pressure waveform, because this is what is going to tell you the integrity of the ventilator, because you are using PCV, pressure control ventilation, is the pressure delivered correctly. So when the valve closes, the pressure starts building up in the lung. It reaches a point which you said you are given a control to the machine. You cannot go up beyond this. So this is a peak inspiratory pressure. It will stay at that pressure until the valve opens. Then it will fall drastically. So this time until it opens, from the time valve closes and until it opens is a inspiratory time. And it will fall. Once the valve opens, the pressure will fall until it reaches a level where the ventilator will not allow further fall of gas, because gas is coming from here which will develop some pressure here. So it is set in such a way that it will not touch zero. This is zero. It won't touch zero. It will stop short here. This is a positive end expiratory pressure. So now you have learned three terminologies: PIP or peak inspiratory pressure, and positive end expiratory pressure, and inspiratory time. Now after this, what happens? After valve opens, it will remain open till the next breath starts when the valve closes. So this is your expiratory time, and the total of inspiratory time and expiratory time is the full time for a cycle of breath. That is your time for respiration or ventilator rate. I hope these concepts are clear. We can discuss further subsequently. Now let me come to how this pressure waveform works. We said, unlike in a normal breath baby, it is a positive pressure. So you never find a negative pressure until the baby breathes. You will always find a positive pressure. From PWP, when there is a trigger which causes the breath to begin, and it reaches up to a point that is a limit. Something will tell the machine, okay, stop, no more increase in pressure. That is your limit. That is your pressure. And then, so this is going to regulate the gas flow during this breath, and then it will remain at this until you say that, okay, now time, open the valve. So this is the cycle mechanism. So three things will tell you what mode of ventilation you're using, whether what is the trigger, what is the limit variable, and what is the cycle mechanism. Now trigger let me just, to understand this concept, we'll go slightly deeper into trigger. So what causes the breath to begin? All machines have time triggers. So this is the time is the common one that is used. But if you allow the baby to breathe, you need to have a flow sensor connected to the ventilator which will detect a slight change in pressure or flow. So the change when the baby want to breathe, there will be a slight change in pressure. The pressure change will be a negative deflection, or there is a flow dip which the machine senses, okay, now time to trigger. So the trigger can be time, pressure or flow normally. But in modern day ventilation, we need to use flow sensors which are the most ideal ones for ventilating, not pressure sensors. So, and as I said previously, precision medicine means let the baby do. So gentle ventilation, do not set time, ask the baby, you choose time. So you don't want to, unless force, you don't want to use time, you want to use pressure or flow, we would prefer flow. Now people have looked at other modes to dictate the baby's breath, like the chest impedance, abdominal movement, etc. Or recently, people have looked at the electrical activity of the diaphragm. This is a new mode of ventilation, the triggering based on the NAVA, the neurally adjusted ventilatory assist, came in 10 years ago. We thought that is going to be the future, but unfortunately it disappointed after a point of time. We will not discuss in this module. That is for a different thing, but probably. So the trigger can be time, pressure, flow, chest impedance or abdominal movements or the electrical activity of the diaphragm. Now, the limiting variable is going to be pressure, I said. The cycling mechanism, what causes the cycling? If you give the baby if the baby is not going to tell the machine anything, or machine is going to take total control, it's going to be time. After the inspirated time is over, it will cycle. But if you allow the baby's flow to be respected as a parameter for cycling, then you are giving more freedom to baby. So this mode is called pressure support ventilation. So here it's a flow termination flow is what terminates the cycle. Volume cycling is not used in neonatology. I will not discuss that. So now we have 4 basic modes for ventilating a neonate. I would just summarize it this way. We are going to have a session tomorrow on expanding on these modes. What are the differences and all these? I will just tell you the intro only of this, and then how to initiate. Tomorrow we are going to discuss this. So the 4 basic modes: total machine control, that is a continuous mandatory ventilation or intermittent mandatory ventilation. This is a mode that we used when we started ventilating babies in the 80s. And then we realized that no, we need to give control to the baby. So we need to start synchronizing the breath with the baby. So synchronized modes came in. All these are synchronized modes. And of the oldest one is the synchronized intermittent mandatory ventilation, or SIMV. And we have also another mode that is called by different terminologies in different ventilators. The dragger calls it SIPPV. The newer dragger, the VN500 and so many other machines calls it assist control. SLE calls it patient triggered ventilation. Actually, all these are patient triggered ventilation if you are really using the correct terminology, because they are all synchronized modes. But SLE, the terminology is right for this. So I put all these together and I will just call it as SIPPV, not because of any affinity to dragger, just to understand the concept. So SIPPV, assist control, or PTV, is a mode where you give even more freedom to baby, and PSV is where you give maximum freedom. So probably when we ventilate, these are the 2 modes that we should be using more and more. Trigger, as I said, this only machine can trigger. Here it's a baby all the way in all the 3. Only when the baby stops breathing, like in asphyxia, apnea, then you set a backup rate for the ventilator. So in SIMV, this rate is important. You need to play with it. That's why I don't like the mode of SIMV. It's very unphysiological to strain the baby and make the baby breathe through a straw. So probably there comes the role for the modern mode of SIPPV. So anyway, all these are modes that will help the baby to trigger as well. Limit is always pressure, and the cycling is by the machine in all these 3 modes, and by the time that you set inspirated time. Whereas in pressure support ventilation, the flow, so the baby is what is deciding. Now PSV also, if you you should not put all, that doesn't mean that you go back and put all babies on PSV. What will happen is that if baby does not have its own flow, or baby is too preterm to actually give the correct flow, then probably you will create problems. So those babies would do better with a SIPPV. So probably PSV is a mode for mature babies where the baby's flow is used to cycle. Now we said that pressure limit is what we use, but then we want to have the best of both worlds. We know that volume targeting, I began my lecture by saying that what is the parameter that you want to target? Tidal volume or minute ventilation. And I am not showing any volume here. So we started looking at, is it possible? With volume control ventilation is impractical in preterm baby, in neonates, but there is another possibility. You set a pressure limit, and then you allow a particular volume to be delivered, and once that volume is delivered, you cut off the pressure at that. So this is the hybrid mode called volume targeting, which is the mode of the future, or actually the mode of the present in this century. This century, volume targeting is probably what we should be doing. We'll discuss this in the subsequent sessions. So let me summarize. The 4 basic modes for ventilating a neonate are CMV or IMV, SIMV, SIPP or assist control or PTV, and PSV. Now which is the best? Probably after having said all these, if you know only IMV, you will say more babies with IMV. If you are still trained in SIMV, you should not try this unless you are trained in this. So probably the mode that you are most familiar with is going to be the one that is going to give you maximum outcome, best outcome for the baby. Now we will look at the basic concepts in oxygenation CO2 strategy. I made it very, very simple. I don't think I can make it any simpler than this. Just one slide, how to oxygenate. Oxygenation depends only on two parameters: the FiO2, the fraction of inspired oxygen that you give, and the mean airway pressure that you deliver. Only these two parameters as far as the lung is concerned. I told you previously, ventilation and oxygenation are different. By ventilation alone, you cannot control oxygenation. The heart has to take the pump, and the blood, RBCs have to take the oxygen. The hemoglobin has to carry the oxygen and deliver to tissue, and tissue should be healthy to take it up. So oxygenation per se, the PO2 will not really depend on lung alone. But if other things are all normal, then probably oxygenation, or rather, as far as lung is concerned, FiO2 and MAP are the only two parameters that will determine your oxygenation. Let us discuss this. FiO2, of course, I hope most of you are attending the NNF Kerala's, or rather the combined IAP Neonatology chapters, Learn from the Legend series, where we inaugurated with the oxygenation, where Professor Ola, the legend of oxygen therapy, talked to us about this, starting with air. So FiO2 is air, or rather 21% when you start with in the delivery room. But then here we are talking about a sick baby, so the FiO2 has to be anything between 21 and 100%. So if the baby is not oxygenated well, you would increase the FiO2 from 21 gradually up to 100. So FiO2 is a parameter tool for you to increase oxygenation, but that's not enough. Sometimes the lung compliance and resistance plays a spoil spot. So we need to know one terminology called mean airway pressure. Mean airway pressure is what determines oxygenation. But unfortunately, in conventional ventilation, you don't have a button to increase or decrease MAP. You have instead 5 buttons to control MAP. Peak inspiratory pressure, peak end expiratory pressure, inspiratory time, flow, and expiratory time. Now, all of this will affect mean airway pressure. So, let's define what is a mean airway pressure. Mean airway pressure is the area under this pressure volume curve from the initial, when the valve closes to another time valve closes, which means that full cycle, valve closes and valve opens, and then again valve closes. So, till this period, the pressure generated, the area under this curve, this is your mean airway pressure. That's a simplified version of mean airway pressure. So if you want to increase this area, you can do so many things. If you increase the PIP, you will increase the mean airway pressure and oxygenation. If you increase the flow from a sine wave, your pressure waveform will become a square wave. I am introducing two terms now, sine wave and square wave. If the flow is very fast, high flow, the peak pressure is reached very, very fast. So increasing the flow will convert a sine wave to a square wave. So increasing flow will increase the area under the curve. You can also do another thing. What you can do is, if this is the inspiratory time, if you don't allow the valve to open here, if you wait till here, you can again get more. So if you increase the inspiratory time, you can again oxygenate more. Or if you increase this line to here, PEEP, end expiratory pressure, if you increase again, you will oxygenate more. And if you respiratory rate is fixed, so if you increase this, obviously the same thing can be said as reducing the expiratory time. All these are going to improve your oxygenation. This is a very simplified version. We know we live in a very unperfect world. It's not very easy to just tamper these buttons and get the proper saturation. But these concepts you should always keep in mind when you tamper when you fiddle with your buttons. Now let's come into proper ventilation, CO2 removal. That is what is actually all truly representative of the ventilation, and this is determined by, I told you, the gold standard is alveolar ventilation, which is which cannot be measured. You can only measure minute ventilation, which is a product of alveolar ventilation and dead space ventilation. So dead space you cannot calculate. So minute ventilation is the best parameter you have. It is, the calculation is by tidal volume times respiratory rate. This we all know. Now, respiratory rate, you don't have control. You may have control in a floppy baby or a baby who is not breathing. But the most of the time when you ventilate in modern era, baby, you allow baby, you don't paralyze, you don't give sedation, you allow the baby to breathe. So, baby will choose its own rate, and you only have control over tidal volume. So, tidal volume is the parameter that you would be really controlling for CO2 removal. So, minute ventilation, I said you should target. So after controlling tidal volume, you should be getting a minute ventilation of 200 to 300 ml per kg. And tidal volume, you should be targeting 4 to 6 ml per kg, or either start with 4 to 6 ml per kg. It doesn't always work like that. All of those of us who ventilate know that. Now, tidal volume can be increased by increasing this, what is called delta P, which is the difference between the peak inspiratory pressure and the peak positive end expiratory pressure. So, by increasing PEEP or reducing PWP, you can increase the delta P, and that is going to increase the CO2 removal. This is again a concept that is oversimplified, but remember this as we discuss more and more things. So now, I have covered most of the basic concepts, what I thought you should know before we start with this session. So let's have two clinical problems. One is, both are real cases. A 28 weeks gestation baby, 1000 grams, 3-day-old neonate had to be ventilated, and in our unit we use SIPPV as a primary mode with volume targeting, but I am not putting it because if you discuss volume here, then you won't understand the concept. So volume I am taking off. Ideally, you start with volume in preterm. I will tell you in the next session or the next this thing. So these are the settings. You have pressures of 16/5, FiO2 70%, respiratory rate is 60, minute ventilation is 0.12 liter per minute, saturation 85, and this is your blood gas, pH 7.23, PO2 39, PCO2 68, and base deficit 3. So great. So it is a great answer. So like most of you, so rather the answer, we know that here the problem is high PCO2 as well as low saturation. Why? Because so you want a saturation 90 to 92 is the target you want in this baby. You won't want anything less than 90, and you don't want more than 92 or 94. And what is the minute ventilation here? You have 0.12 or 120 ml, 1 kg baby, I made it simple. So 120 ml per kg, which means that it is less than 200. So you have both CO2 is high and your low saturation also. So you need to address. Now, how are you going to solve this problem? Again, please vote for this. You will increase the FiO2, you will increase the PIP, you will increase the PEEP, you will increase the respiratory rate, or increase the flow. Great. So as usual, everybody, the majority is always right, isn't it? So probably what is the advantage of increasing the PIP? I just gave you the answer in the previous this thing. That way you will make sure that both problems are taken care of. When you increase the PIP, you will increase the tidal volume as well as you will increase the mean airway pressure. If you do any of the other parameters like increasing FiO2, only oxygenation will be taken care of. If you are going to increase PEEP, of course oxygenation will improve, provided PEEP, one important thing is that you should keep the adequate or optimum PEEP. If you keep higher than that, you are actually ventilating in a dangerous zone. So we presume that the PEEP 5 was appropriate here, and if you increase the PEEP, this delta P will come down. So the pH will further worsen, and increasing rate will only tackle the CO2 and increasing flow only oxygenation. Perfect. Now another baby, 25 weeks, 500 grams, 4-day-old, ventilated on SIPPV, pressures of 20/5, FiO2 24%, respiratory rate 40 per minute ventilation per 8 ml per minute, 80 ml per minute, saturation 92%, ABG 7.20, pH 64, PO2, PCO2 70, and base deficit is -2. So what is the problem here? So I'm admit these are very simple questions. I wanted to make it simple just for the reason that probably you the concept is only to wake you up. I know that all of you are aware of the concept. So here we accept the concept of gentle ventilation, which means that any PCO2 between 45 and 55 is okay for us, but not 70. 70 is too high. People have stretched gentle ventilation concept to up to 60, and we don't want textbook values of 7.35 to 45. That's again a crime, hyperventilating. So we want a PCO2 of say 45 to 55 in this baby. PO2, it's okay, 60 to 80 is what you want, so perfect. So pH is, we want a pH, the pH target when you ventilate is between 7.25 and 7.35. Nothing more than 7.35, nothing less than 7.25. Probably I would prefer a pH between 7.28 and 7.3. That is where you deliver the perfect ventilation. Okay. So now the problem is high PCO2 and low pH. Now what is going to be the solution here? Can you again vote for this? What are you going to do here? You will increase the rate, increase the PIP, increase the PEEP, decrease the PEEP, or increase the flow? A simple question. So probably in the next session we will have more sophisticated question. These are or complex problems where we probably won't know the answers. All of us won't know the answer. But this is a very straightforward case. So here the problem is only with ventilation. Oxygenation is perfect. So if you tackle any other problem other than increasing rate, if you increase PIP, what is going to happen? The oxygenation also will increase. We don't want to provide cause hyperoxia. So probably we don't want that. And if you increase PEEP, again, it is going to be opposite effect. The PCO2 will further worsen and decrease PEEP. What is going to happen? Your oxygenation is perfect here, and that's not going to help. And the increasing flow is only for oxygenation. So here the problem is ventilation. So this is again, so minute ventilation can be improved by increasing rate also if you don't want to touch the tidal volume, because if you touch tidal volume in conventional ventilation, eventually you will end up with tampering with oxygenation. If oxygenation is perfect, then you have only rate to play with. Like if ventilation is perfect, you have only FiO2 to play with in, or rather there are other buttons also conventional. Now in high frequency ventilation, probably we try to dissociate. So-called dissociation is there even though it is not perfect. Okay, now the last part we will just another 2 minutes we'll spend on what's so great about volume targeted ventilation. We said that limiting variable is always pressure, but what is volume targeted ventilation? What you try to do is, even though you have kept a PIP limit or pressure limit, you call it PIP max, maximum pressure the baby is allowed to breathe at. But you don't keep a minimum or the mandatory pressure, which means that you set a tidal volume, and then when the tidal volume is reached with any pressure before that, you immediately stop the pressure at that point. That is the hybrid mode. So this is called targeting volume. Targeting volume. So in neonates, this is a newer mode, not relatively newer. It was newer in this century. Now it's a standard mode which we should always be using. Now, can I have the last poll? How many of you are targeting tidal volumes while ventilating neonates? If those of you who are ventilating, if you could kindly answer. This is just a curiosity, because there is no, I said the best mode is what you're most familiar with. Okay, it's a mixed bag. Most of the time, most of people say that probably that would be the most practical thing to do. Probably the ideal scenario would be to target all the time. It is practical. I think like my unit, most of the units who use this would be swearing that that is very, very practical to do it. Targeting volume is the better way to ventilate a neonate. Use all the parameters that we learned to target volume. Try to get 4 to 6 ml per kg of tidal volume, or try to get a minute ventilation of 200 to 300. That is the way to ventilate. There is enough evidence. This is one of the best papers that I found. It's not very new, 2014. After that also there are various papers. All the outcomes that you really want in short-term outcome, mortality, any IVH, grade 3-4 IVH, BPD at 36 weeks, cystic PVL, pneumothorax, failure, any hypocapnia, duration of supplemental oxygen, all these are less, or rather are better outcome when you target ventilation in the volume, target volume instead of limiting pressure. However, some of them are not statistically significant. We have Cochrane reviews right from 2010, various reviews which have also showed us that outcome is we should always be targeting volume. So to summarize the evidence so far acquired in this century, last 20 years, there is definitely statistically great significance improvement in the short-term outcomes. And I would say that should be, by default, should be adopted as a primary mode in preterm infant. You should use hybrid mode of targeting volume. It's called by various terminologies in various ventilators. Like in your SLE, you call it TTV, targeted tidal volume, and Rager, you call it volume guarantee. Well, they are all terminologies that are trying to say the same thing you are trying to target. It is not always possible to target because of the various things, and one of the biggest bottleneck that you're going to have is the flow sensor. If you don't have a good flow sensor, targeting fails. But long-term outcomes so far, there are some studies going on, the results are not yet out. But looking from the trend that all the short-term outcomes are improved, we expect that long-term outcomes also should be better. Let's see. And we need to research on further refinements and long-term outcomes. So I'll finish here to summarize. Lung characteristic, how you ventilate a lung depends on a normal lung or an abnormal lung. So you should look at the compliance, resistance, and then decide what is the time constant, and then set your inspirated time. And oxygenation depends on MAP and FiO2. MAP is depending on PIP, PEEP, inspired time and flow, and CO2 removal depends on minute ventilation, which is a product of tidal volume and respiratory rate. And always remember this graph. This graph will keep coming to you all throughout this 6 webinars. Ventilate here in the green zone where you are after the critical lung opening pressure. You ventilate here to cause minimum ventilation induced lung injury, because if you ventilate in any other zone, you cause VLI, ventilation induced lung injury. We thought barotrauma is the worst, but we now know that barotrauma, which is a direct effect of the pressure limited ventilation, is not as bad as volutrauma, which you cause when you don't use volume. So volume, that's why volume targeting is should be the norm. There are other forms of injury which if you just give one breath, you cause some cytokine changes. So the biotrauma, then the flow of gas is going to disrupt the mechanism. So rheotrauma, there are various traumas that you have in VLI. So all these you should be aware of. So, and then if you're going to ventilate without adequate PEEP, you're going to cause attenuated trauma. So for PG, those who are still studying for post-graduation, these 5 ventilation-induced lung injuries are common asked questions: the barotrauma, volutrauma, rheotrauma, biotrauma, and atelectotrauma. So probably we should aim at ventilating with giving maximum control to the baby, which is not always possible, because pressure support ventilation means baby should have an intact brain and should not have apnea prematurity and things like that. So probably you end up with the next best thing, that is SIPPV. But use what if you cannot use, you can use SIMV also, but use volume also, targeting volume also. And I'll end here by just reminding you again of one of the things that we are taught right from the time we join for medicine. First, do no harm. Ventilation is going to cause harm, and until you ventilate the baby properly, you are going to cause harm. And ventilation properly doesn't mean normal gas. Let us not get normal gas. We don't want a pH of 7.35 to 7.45. It's a crime to get a pH of 7.4 in an extreme preterm baby. We want gentle ventilation. So from science, the ventilation has gone on to the art of actually titering to the baby's demand. You accept higher CO2s up to say 55 or even 60, depending on, now we say previously it was 60, now we say 55 PCO2, and accept you don't really accept hypoxia, but let the PO2 be between 60 and 80 even when the baby has pulmonary hypertension. And then pH, let it be something like 7.25 to 7.35 or 7.28 to 7.3. These are general concepts in general ventilation. There are various other concepts like use of volume targeting, and of course individualizing, looking at the lung pathology and starting with lower values. Suppose you are ventilating with a normal lung, do not start with if you are not using volume, do not start with pressures like 18 and start with 12 or PIP of 12 or 10 or something like that. So there are various ways to improve and be more and more gentle with our babies. I finished, so now I can take questions. Thank you.
Varma sir. Varma sir is there?
Dr. Varma? Okay,
I think Varma sir has called me. He has got some connection issues, I think. So in the delegates list I can see, sir. But
hello. Hello.
Yeah.
Yeah. I think I couldn't unmute. Thank you much for that wonderful session. Am I audible?
Yes.
Right. As you were saying, ventilation is an art, and most of the time it is not the ventilator that matters. It is the person who is ventilating the baby that matters. Just like the stethoscope, it is not the stethoscope that matters. It is what is between the two earpieces. There are some questions in the chat box. Please use the chat box only for questions. One is a very basic question: how resistance is low in RDS?
Okay, so it is like it's a very simple thing. If you have it is very easy to flow gas through a rigid pipe. It goes very fast. The resistance is not there only. So it is difficult if the pipe is actually very flabby, and then you knew the flow will not take place properly. So rigid tubes resistance is low. That is basic physics.
Right. Okay. Thank you very much. The next question: would the mode you choose depend on the pathology of the lung? Another question on that same thing is: will you call volume targeted ventilation best for only the extremely preterms?
Okay, the mode will definitely depend on the disease pathology. Like I will tell you one example. The one of the rare scenarios where I use SIMV, I don't use SIMV in my unit, is when in a baby with meconium aspiration syndrome. The typical meconium aspiration syndrome initially is that the meconium is an irritant. It will keep irritating. Baby will have very fast breaths. And SIPPV, every breath that the baby takes, machine will think, okay, this is a needed breath. So it will start giving the breath. So that is where you say enough is enough. Sometimes it's better to spare. It is not. If you spare the child rod, you will spoil the child. So we need to take control. So that is one of the occasions. Otherwise, for like if you would not try to PSV, I said is the best mode in a baby who has normal brain. So if baby has asphyxia or a preterm baby who has apnea prematurity, I would not try to start with PSV. So definitely it depends on that. And second question, absolutely, I am very sorry if I convey that is volume targeted ventilation should be used for all babies, not for preterm, but it matters most for preterm babies. That's all. Definitely it has to be used in all babies.
Now, one thing somebody has asked is probably you couldn't catch what time constant is. If there is a recorded video, you can probably go through that.
We are actually providing please visit the NNF Kerala's YouTube channel. All the sessions that we do, including our Learn from the Legend series, are available in that. The link, if anybody want, they can personally message us, or we can you can write to kerala@nnf@gmail.com. We will send you the link. You can watch again. Time constant is a very. I try to make it very simple. It is like the product of compliance and resistance. So like you should know some value which you should start with. So if you know that a baby's lung in this disease has high resistance and high compliance, like BPD, I know that I should not use an inspirated time of 0.3 to start ventilating. I should use 0.4. Like in RDS, if I am going to use, how do I know that? Only if I know the time constant, I will know this. And in a RDS, when your compliance and resistance both are low, your time constant or the time required to flow gas is much less. So you would use 0.3 or 0.28 depending on the thing, and then 0.3 for whatever the value depending on the disease. So it is a value that will help you in setting your time, inspirated time in various disease pathologies. I hope I have made myself clear. Otherwise, we can discuss. Please post your queries. We could continue the chat in the as an email in the kerala@nnf@gmail.com. Thank you.
Another question is, if the baby is not sedated, is there a role for changing respiratory rate to wash out carbon dioxide? That is one question.
Baby should never be sedated.
The baby is not sedated.
Baby should not be sedated. That's how we ventilate. Except in a case in a severe PPHN, and then your baby is on high frequency oscillator, and you really want to take. That's a different scenario. We're not discussing. Otherwise, baby should always be sedated. So baby should never be sedated. The baby's breath depends on the mode. Actually, the rate is depending on the mode. Suppose you are going to use SIMV. Then probably the SIMV, the basic problem is that the backup rate, that the respiratory ventilator rate that you set only will be supported. So you should set enough, like 40 or 45 should be a rate. Whereas in SIPPV, you can use lower breaths. Even if you keep 30, if baby breathes more than that, and that is enough, more than that, all will be supported. Baby wants only 30 to maintain normal this thing, that will also be okay. So definitely rate has to be chosen intelligently. I hope that clears that question.
Probably that was the answer. And that answers the question, is sedation mandatory for a good ventilatory strategy? Most of the time you don't sedate. That is the answer. Now, somebody has asked, what are the usual settings you start with?
what are the usual settings? I start with like
Scenarios like preterm in a meconium, you can say probably that way.
this is a question that my fellows ask when they join. What is there is no tailor-made answer, but then I'll just try to give some starting point. Like if you are ventilating a preterm, if you decided usually you don't ventilate, but if you ventilate the baby, probably you may start with a PEEP of 5 or 6, 6 probably, and a tidal volume. So of say depending on lower, suppose you are talking about a 27-28 weeks, I would start with 6 ml per kg, and if I am ventilating a 34 33 weeks, I would start with 5 ml per kg, and term baby 4 ml per kg. And there is another parameter which you need to set in ventilator called PIP max, that you set 20% more than what is required. So probably if you don't know the value, you can set it slightly higher also, no problem. 30 PAP max you can set. And then FiO2, depending on oxygenation is a different thing, you can set up on the rate. Rate is depending on the mode. If you are using SIMV, then probably you need to start with 45 or 50. Otherwise, you can start with 30 or 40, 35 or 40 if you are using SIPPV. I hope the settings are clear. Now, in term babies, 4 ml per kg, PEEP of say 5 or 6 depending on the disease pathology, and then rate again depending on the mode.
Right, okay. Now, two questions can be clubbed together. One is, what is your weaning strategy, and when will you try to extubate, and what is the criteria for extubation?
We have a whole session on weaning strategy. It's a talk by itself. So probably after that session, that is on, after that session, I'll be talking again on pulmonography. We can discuss if it is not clear. Otherwise, the whole time will be, it's a topic by itself, weaning strategy. But the basic thing is, when you put in a tube, the moment you put in a tube, you should be worried. When am I going to take it out? So the idea should be, the goal of intubation should be extubation, which means that you should be all the time looking at weaning strategy. The earlier you can extubate, the better it is. How do you do that? Various strategies we'll discuss subsequently.
And another thing is, what is your take on permissive hypercapnia? There is some confusion there. Somebody has got regarding permissive hypercapnia.
I thought I answered it already in my lecture. Permissive hypercapnia is a terminology that you use to allow higher CO2. The advantage is that you don't really take total control. Higher CO2, we know, will stimulate the respiratory center, and baby will be stimulated to breathe. And when the baby breathes, automatically the CO2 will come down. So this is a concept. Previously in the last century, when we were ventilating, we were always targeting lower PCO2s like 40 and 45 or 35 and 45 and all that. So what has happened is that we found that the studies have found that the incidence of brain injury is much more at that time. So you don't want lower CO2 and brain injury. So that is why, and the values, if you ask me, I already said, probably the values I would follow is PCO2 of 45 to 55. Some people go up to 60 also. You have to be careful when you use anything more than 55 on an arterial blood gas, because the even higher CO2 also can cause problems.
Right, I think this is already answered. Is volume targeted ventilation the ideal for only for as a weaning strategy? But I think you have already answered that question.
Please. It should be right from the time you ventilate, not when you wean. When all the work is done, by you are damaged the lung already, and then you want to protect. What do you want to protect by volume strategy? Volume targeting is to protect your lung from unnecessary volume trauma. By unnecessary, baby's lung improves, the pressures automatically comes down. It is called auto weaning. So you should use it right from the time you ventilate a baby. I know the practical problem is that flow sensor. You should have good flow sensors. Then only, if you have flow sensors get clogged with secretion and all, it doesn't work. Then it becomes a real hell. So that is, otherwise, always right from beginning, you should target volume.
There is another question. If the baby is breathing lower than the set respiratory rate on ventilator, would weaning the rate help in blowing off carbon dioxide?
Baby is breathing lower than the set rate. How will the by lowering further, how are you going to, it depends on what are the values you're talking about. If you are talking about SIPPV, if baby's brain is normal, the CO2 will automatically come up. If it doesn't come up, you have to increase the rate. SIMV is a different ball game. SIMV, if you are using, then probably it is an unphysiologic mode. Because if baby is breathing more than the set rate, what is actually happening is only the set ventilator rate, the machine will give support. The rest of the rates are baby is not supported fully by the machine. So you need to use something like PSV along with that. Not a perfect world, but that's what you should do if you want to stick on to SIMV. But SIMV alone, if you use, what is going to happen is that other breaths, other than what you have set, baby has to breathe to a straw. Like just imagine you go underwater, put a straw and try to breathe. The work of breathing, which will go up. What are we ventilating for? To bring down the ventilator with the work of breathing. And if you use SIMV, you will take longer time to extubate because the work of breathing never comes down fast. Take it from me.
I think somebody has asked for some tips on tube leak, tube block, and flow sensor malfunction, position of the baby. I think position of the baby during ventilation, you can say, and something on leak also.
So these topics are coming up. Probably the answers, because this is only the intro topic. If the questions are not answered at the end, probably next week, let this week's lectures be over. After that, if they are not answered, definitely we will discuss, I think. If it's up.
We will end it there. Thank you very much for Dr. Manoj for that wonderful session. And thanks to all the delegates who had been here. And thanks to Dr. Murali for asking me to chair this session. And I hand over now to Dr. Reti, if she is still there. Is she still there, Reti?
Thank you so much for a patient hearing. I'm really honored to have you all here for almost 1.5 hours now.
Reti is not there, I think. Srijit, you can take over. Or Murali.
Yes, sir. So we have a very fantastic start, excellent start to a webinar series, and 5 more webinars are coming up, and we have a very good attendance also. And sir also already mentioned, those who missed the initial parts or some parts can go back to our YouTube video in our NNF Kerala website, and please go there. And I must congratulate Manoj sir for an excellent presentation. This topic is dealt in a very easier way. And also Varma sir for moderating its session. And also thank all the team leaders of the NNF Kerala team and Thrissur Neonatal Forum, and also the IAP Thrissur team. And I expect all of you join today to join us tomorrow also at the same time at 7:30 p.m. And we have Dr. Murali Raj speaking on the different modes of ventilation and initiation of ventilation. So I expect all of you to join tomorrow at 7:30 p.m. tomorrow. Okay. And good night from you, JIAP and JNNF.
Thank you.
Thank you. Thank you.
Thank you.